Hey guys, so my clinical pattern project is avascular necrosis of the femoral head, and this is a type of osteonecrosis that is due to the disruption of the blood flow to the proximal femur and femoral head, and it can lead to a collapse of the femoral head, and this would indicate surgery. So demographics for AVN, the average age of onset is 36, and males are at a higher risk than females. So the ratio is 3 to 1, and then I saw another ratio in the literature that was 5 to 1. So either way, significantly higher than females. Outcome tools, Harris hip score, and the numeric pain rating scale. Mechanism of injury. So for the mechanism of injury, basically thinking of any type of traumatic injury that is going to disrupt the blood flow to the hip and femoral head. So a car accident or anything that's going to cause a fracture of the femur, that could lead to AVN. So like I said, a motor vehicle accident, a traumatic fall or something like that. And then also you could have disruption caused by like a occlusion of the vessel, or compression can also cause AVN. Aggravating factors, these patients tend to not like weight-bearing activities really, especially at later stages of AVN. So standing after sitting for a prolonged time, walking, running, jumping, high-impact activities like that, they're not going to like. And then easing factors are positional, so lying supine, prone, and then positioning on their contralateral hip side is going to be easing in some cases. And then medications such as anti-inflammatories or muscle relaxants. The 24-hour pain pattern. Symptoms are activity dependent, so as the day progresses, so is their pain most likely. Systems review. So if there's any of those red flags that we've kind of discussed in class, the unrelenting pain that isn't easing, or the therapist can't make it better or worse, then you might want to do a systems review there. Also, if there's anything indicating an infection or something like that, then that's going to be an indication for systems review. Precautions and contraindication to examination and treatment. So if they have a high irritability and pretty much anything you're going to do with them is going to cause them to be in pain, then you might want to defer a full examination to a later date, because you don't want to cause them to go into more inflammation, and you don't want to cause them to be in pain. So if we're talking about the range of motion, active and passive range of motion are both going to be limited and painful in the capsular pattern. So the limited and painful in hip flexion, hip abduction, and hip internal rotation. As far as resisted testing, you might see pain with those motions, but you're really going to see relatively weak hip flexors, hip abductors, and hip external rotators. So the musculature that's supporting the femoral head. If we look at accessory mobility testing, you may find an empty infield secondary to pain, and then you may find hypomobility or abnormalities at like the foot and ankle or knee due to poor hip mechanics and the pain that they've been in. Neurodynamics, there's not much here with AVN. Palpation, you're going to see that the posterior hip musculature, so the glutes, the piriformis, those are going to be tender to palpation. And then as far as special testing, hip scour, Faber, and Fadir, those all are going to be positive in this case. And then differential diagnoses, so you've got lumbar radiculopathy, spinal stenosis, labral tear of the hip, snapping hip syndrome, or even like a primary bone tumor. So those are things to look out for. The gold standard for diagnostic imaging is an MRI. There's radiography too, but gold standard is going to be MRI. Signs and symptoms for referral. So basically, if there's any of those red flags we kind of talked about earlier, so unrelenting pain at night that you can't make better or worse, you might want to refer them there. And then also if there's anything that's indicating a fracture, that's going to indicate surgery, but you also are going to want to refer them as well. And then if there's anything, since it is a vasculature issue, if there's anything indicating a DVT, so the tenderness or warmth or pain in the calf, then you're going to want to refer them. So surgery, there's a couple options. The gold standard is going to be total hip arthroplasty, and this has been shown to effectively decrease pain within a year post-surgery. So that's crucial. And then there's also things such as surgery such as core decompression and then total hip resurfacing or bone grafting, but all the most, these are going to lead to a THA. And basically, surgical indicators are going to be if their status has changed with weight bearing. So if it becomes way more painful to weight bear, then that might indicate that there's been a fracture that has gone on, and then or a collapse of the femoral head, and that's going to indicate that they need surgery. Thanks, guys.